Good evening, and welcome to the first in a four-part series on the coronavirus sponsored by Rhodes College. I'm Cary Fowler. I'm the chair of the Board of Trustees at Rhodes. Today, we passed through a heartbreaking milestone of 100,000 deaths from coronavirus in this country, almost a third of the global total. It's estimated that an average American knows about 600 other people, and that seems like a lot to me. But even if an average American only knew 100 or 200, what this would mean was that many of us have already been touched and experienced loss from COVID-19. It seems inevitable that we will all know someone who is perhaps felled by this disease, someone who's been infected, someone who's gotten sick, and certainly we'll know people who have lost their jobs and become unemployed. COVID-19 is affecting poor communities and communities of color disproportionately. We can't be surprised by this, or at least we shouldn't be. But it's affecting everyone economically. Everyone is feeling vulnerable. Everyone is experiencing anxiety, uncertainty, stress, maybe fear, and everyone's life has been disrupted in big and small ways. We're all getting cabin fever. Some of us really need a haircut. It's in times like this that we can either seek refuge in quick and easy answers, solutions, or we can seek a deeper understanding of the world in which we live. It's a world that includes viruses. The liberal arts tradition at Rhodes means that we try to look at all aspects of a problem, including all of their inconvenient complexity. And it's this kind of approach at Rhodes that's helped us create such a vibrant community of scholars. And if I dare say so myself, I think it's why we produce graduates at Rhodes that are in such high demand. Why? Because they have the critical analytical skills to understand and grapple with complex problems. When the going gets rough, it's this type of thinking and these types of skills that help us solve problems and fashion creative, workable solutions to the big problems of the world. During this four-part series, we're going to look at COVID-19 from a number of different perspectives, including through the lens of history and literature. We are going to examine the effects on our society, on economics, and on higher education. And finally, we are going to ask the question, how can we as a society, as a community, and as individuals begin to cope with this terrible disease? This evening, however, we are going to focus on the science. For the next hour or so, we're going to look at the science, and we have three really excellent panelists. A mathematician that's going to help us understand predictive modeling for the virus. We have a virologist, and we have a professor of medicine and a practicing physician to help guide us through some pretty complex issues. They're each going to give a short presentation, and then we're going to open it up for questions and answers. And that's when you, the audience, come in. If you're catching us through Zoom, you can look at the bottom of your screen and you'll see a Q&A button. You need only press that button, and that will give you a screen where you can type in your question. You can do that at any time. You can start right now. You don't have to wait until all the speakers have finished. With that as an introduction and to have given you that little bit of housekeeping, let's start this panel. We have three panelists, as I mentioned. We have Dr. Erin Bodine, who is an associate professor and associate chair of mathematics at Rhodes College. We have Dr. Lindquester, who's professor of biology. And we're pleased to welcome Dr. John McCullers, who is a professor and chair of pediatrics at the University of Tennessee Health Sciences Center, and also the chair of pediatrics at Le Bonheur Hospital. So first up, if you'll get us started, Dr. Bodine, Erin, can you give us a brief introduction to epidemiology and to the various kinds of efforts that are underway to do mathematical modeling to help us predict where this virus is going to go?
Yes, I would be delighted. I have a few slides, so I am going to share my screen. So let me just start by saying that I'm a biomathematician, and so I use mathematical models to simulate things in the biological world. So this means, dynamical systems, anything that's changing over time, are things that you can use mathematical models to simulate and to study to make predictions. And over the years of my research, I have used models to study a variety of different infectious diseases, including HIV, MRSA, which is the drug-resistant staph infection, Ebola, yellow fever, and starting this summer, I have some students that are working with me, and we're going to model coronavirus, the spread of coronavirus. But today I am going to talk about how mathematical models are used to look at the spread of diseases and how they're used to help inform public health policy. So I thought I would start with the two types of curves that many of you have probably seen in the news. It's hard to avoid seeing these in any news coverage. So one of the curves that you might have seen would be a curve of daily rates. So either the number of new cases per day or the number of new deaths per day. So that's this orange curve here. And last night I put together the data for Shelby County, Tennessee. So this is the number of new cases per day. Around day 50, we hit a peak. It started coming back down. This dashed line here is showing when we entered phase 1 and started relaxing some of the stay-at-home restrictions. And you can see that more recently, the numbers are starting to go up there. The other curve that you might see is a cumulative curve. So if we took the number of infections that occur each day and we keep adding them to the total, we get this increasing curve over time. So what's important to know is these are the reported confirmed cases. They don't capture everything, and it's always expected in epidemiology that there are cases that are not being reported that we don't have in the data. So these are likely underestimates. So when we talk about mathematical modeling, there's a whole range of different types of models. So the simplest thing that we could do, which I've shown here in this graph, is we could just fit an equation, a function, to one of these sets of data. So for example, if we were looking at the total confirmed cases in green, we could fit this S-shaped curve to this set of data. There are lots of different types of functions that have this S shape. And one example is this function here. So the F of T, so this is representing the number of total cases at a particular day T. And then the equation over here is giving us this curve. And in mathematical models, there are parameters. So parameters like L, K, and A. So L is the maximum number of cases. So that's going to be where this curve saturates out. K is the intrinsic growth rate, which is going to indicate how quickly this curve increases. So the larger K is, the more rapidly we would see this curve rise up. And then A is the inflection point. And maybe the easier way to think of what this value A is is it is where you get the peak in the new cases per day. So when that is peaked, there's an inflection point in this green curve here. So this is a very simple and straightforward type of modeling where you just fit an equation, you use statistical regression techniques to fit an equation to a curve. But of course, there are limitations to just a single equation model. It doesn't take into account the demographics of the population that you're modeling. It doesn't take into account any public health policies that might be implemented to mitigate what's happening. And so we might want to turn to some more complex models. So in epidemiology, the classic epidemiological model is what's called an SIR model. And most epidemiological models are in a category of models known as demographic models. And by a demographic model, we just mean that we're going to divide the population into different demographic subgroups. And these could be based on what we classically think of demographic groups. So you might break out subgroups based on age, but it can also be based off of infection status or disease status, which this one does here. So this SIR model breaks individuals up into 3 different types of groups. So there are those that are susceptible, that's the S group. There are those that are infectious and can infect others, that's the I group. And there are those that are recovered from infection. And then we build mathematical equations that indicate the rate at which individuals move from one group to another group. So as infectious individuals come into contact with susceptibles, new infections occur. And we can write an equation that basically describes this arrow, the rate at which individuals move from S to I. And then as individuals recover from the disease, they move from I to R, and we can write a separate equation for that. Of course, with coronavirus, there are deaths as well. Not everyone is recovering from the virus, and so you might have a separate equation that is keeping track of the rate at which individuals are dying from coronavirus. So with a demographic model, we can make the model as complicated or as simple as we would like. So this is, the SIR model is considered a very simple demographic model, but we could make the model more complex given what we know about coronavirus. So these models, with coronavirus, we could say, all right, there are susceptible people who are essential workers, and there are those who are non-essential workers. And we could break those apart into 2 separate subgroups. And we might want to do that because each of those subgroups would become infected at different rates, because maybe the non-essential susceptible population is isolating and so has a lower probability of coming into contact with someone who's infectious. We might choose to add an exposed class. So these are people who have the virus but are not showing any symptoms. And then as individuals develop symptoms, we might decide to break the infectious class into those with severe cases and those with mild cases. And then of course we would still have our recovered class and our deceased class. Of course, as the models get more complicated, there are more parameters that we would need to estimate, right? So for example, here there are different recovery rates, whether an individual was infected with the severe form or the mild form. And we would have to estimate both of those. But with these demographic models, we can often use them in combination with data that we have to estimate things like the probability of transmission from a severe case to an essential worker or a non-essential worker, the probability of transmission from a mild case to an essential worker or a non-essential worker. And so they can become powerful tools for predicting very critical parameters for understanding the disease. They can also be used to answer what if kind of scenarios. So you might have heard about a mathematical model. It was talked about recently in the news that the big splashy headline was that if the federal government had imposed its guidelines for stay-at-home 1 week earlier, 36,000 deaths could have been averted. And that was using this type, and not exactly this demographic model, but this type of demographic model, where they fit the model to the data both before and after the stay-at-home restrictions went into place at the national level. And then they said, well, what if that parameter change occurred 1 week earlier? And then they simulate the model over time and they can make the comparison. So models are very powerful for answering these what if scenarios. And I expect there will be a lot of modeling that will be looking at various questions concerning any potential vaccine that comes onto the scene as it's being developed. The last thing that I would like to point out is that with demographic models, if we're looking at just a single population, we would want to look at the total number of total number of cases, total number of deaths. But if we want to make comparisons between countries, epidemiologists often use what's called per capita data. So over here on the left, I have, so this is from Statista. So they're looking at data that was reported as of May 27th of total number of cases in the 8 worst afflicted countries. But if we look at per capita data, which is often reported as cases per million or cases per 100,000, it tells a very different story. So you can think of this as we're scaling by the size of the population in different countries. And so the United States per capita does not have the worst outbreak. We're not doing great. We're number 5, and that's not a place that we should want to be. But it's actually Singapore that is doing the worst. And you can look at the same with per capita deaths, right? So in per capita deaths, Sweden is doing the is doing the worst. And again, the United States is in 5th place. Not a place that we want to be, but we're not the worst. All right, I'm going to leave it at that, and I can take questions later.
Hey, thanks very much, Erin. Next up, Dr. Gary Lindquester. Gary, you're a virologist. So what do you want to tell us this evening about the biology of viruses and the history of trying to develop vaccines for them? I think you're on mute, Gary. There you go.
I'll repeat that. Thank you, Cary. And thanks to all of those of you out there who have joined us for these sessions, and with this one being the first of several to come at the same time weekly. You're right, Cary, I am much more of a virologist than an immunologist, but I would like to talk about vaccines because I think that's what's foremost on our minds in a forward-looking way, and we'd like to keep this as severe as this episode is as positive as possible, and looking forward to that. So I'm going to take a few minutes and fill in some biology background. I can't resist that as a biology professor, and talk a little bit about our immune system, how viruses infect, and what vaccines do and how they come about. And then toward the end, I'll focus on some approaches that are being taken, both kind of traditional and high tech, for the COVID-19 vaccine. So let me shift over here and share screen as well. And hopefully you're seeing an image there with a couple of viruses, cartoon viruses. Note that throughout this, none of the cartoon diagrams will be of any particular scale, and I'm not attempting to be very accurate in representing structures. But these two viruses might be as similar as different types of coronaviruses, or they might be as different as, say, a herpes virus and a COVID-19 coronavirus. But the point that I want to illustrate is that both of these viruses have distinguishing protein molecules on their surface. The red virus has kind of a rounded end on its spike protein, and the green virus has a pointy end on its spike protein. Hopefully you can see that with whatever image you have available to you. Now let's shift and look at some white blood cells that are part of the immune system. We have many different types of white blood cells in our system, but one major type is called a B cell. Notice that each B cell here has a distinguishing protein molecule on its surface, but otherwise these cells are essentially the same. You see 4 different B cells in the picture, but in reality we have millions of different B cells in circulation at any given moment in our bodies with different surface proteins. So the hope is that with this collection of B cells with different surface proteins, then for any given invader, one of these cells might be able to target it. And let me explain what I mean by that. So perhaps you can now see that I combine these figures, that B cell number 1 has a shape, the blue cup at the end of its pointy molecules, that could fit the ball at the end of the red virus spikes, and B cell number 2 has a shape that could fit the green virus, but said B cells 3 and 4 don't match either virus. Now let's assume that this red virus is the one we're interested in. It's infected someone, and the virus has reproduced to produce many copies of it. Viruses and B cells are all moving around in the body in proximity, maybe in the lungs or maybe in lymph nodes. And so the match between the proteins on the surface of B cell number 1 and the red virus is shown here as a binding of those entities together. Now the interaction is much more complex than what I've drawn here, and there's a very strong specificity, almost like a lock and a key fit between these molecules. We say that the B cell has recognized the virus by binding to it. So let's isolate this interaction now and see what happens next. The B cell is stimulated by this interaction, and it goes through a series of changes. Now it also replicates during this process, so there's several copies of it, but I'm still only showing the one for simplicity. This is a highly specialized B cell, and it becomes a factory for making and releasing the proteins that bind to the red virus. See, they all have that same cup shape to them. Now I can tell you these proteins are called antibodies. A single B cell can create as many as 10,000 antibodies per second. That's huge. So here, shifting a little bit, the green rectile represents a lung cell. Note that this lung cell also has a protein on its surface with a cup shape to it, although this is really a very different protein from the other one, yet it can still interact and bind to the same spike protein on the surface of that virus. Now, as the virus bounces around, it might adhere to the lung cell because of those matching proteins. This, in turn, may stimulate that lung cell to take in the virus. The virus has genetic information that I've indicated just with the letter V here. It's now inside the cell, and the cell is said to be infected. The cell's coerced into using the genetic blueprint of that virus and the cell's own production machinery to make many, many copies of the virus. And those are released from the cell. Some of them can go on to infect other nearby cells, and some of them can be spread to perhaps another individual. So now, back to the question of the usefulness of these antibodies. Let's assume that antibodies are present before the virus comes in. And now the virus is in, antibodies bind to that virus, as you see in the picture here. Well, when the virus now bounces around to try to make contact with a cell, it physically fails to do so. Those antibodies are in the way, and we say that the antibodies have neutralized the virus. These are neutralizing antibodies. Now, you may have heard that the goal of a vaccine is to produce neutralizing antibodies, and hopefully this image will help you kind of understand what that's referring to. Now, there are other uses of antibodies or other purposes of antibodies where they're useful. And I'll show you just one more in this slide. The large cell that you see with an M is referencing a macrophage. Now, that name isn't particularly important for this discussion, but it's another type of white blood cell in our body. And notice that the yellow cell has shapes of proteins on its surface that could interact with, match the blue tails on the ends of the antibodies. That means when an antibody comes in contact with the cell, it could bind. And now that yellow cell gobbles up the virus and digests it. So shifting back then to this view, there are a couple of important lessons that I've tried to get across here so far. One is that our immune system responds to viral infection by producing antibodies that very specifically target that given virus. The antibodies then help limit the infection by neutralizing the antibodies, and then help clear the infection by calling out cells such as macrophages to mop things up. The second lesson is something that you might have inferred, and that is if you have antibodies present before the virus gets in, then you might be able to neutralize the virus very quickly and limit infection entirely. And this is exactly why it's rare to get a virus for a second time, because once you're first exposed and make those antibodies, they're present, and because the cells, the B cells that produce those antibodies the first time around, some of those persist lifelong. They produce small amounts of antibody that are present in case you get infected again. Furthermore, the time that it takes to gear those cells up to produce all those masses of antibodies, it's much quicker the second time around. So this whole process that I've described may take 2 weeks the first time, but maybe only a couple of days the second time around because of this cellular memory. Okay, so this finally, hopefully with a little background, brings us to vaccines. The purpose of a vaccine is to induce a primary response to some sort of dangerous pathogen like a virus under safe conditions, so that if you're ever exposed to that real dangerous pathogen, you have a secondary response, you can react quickly, and hopefully you stay well. The obvious question now is, how do you expose someone to a dangerous pathogen in a safe manner, right? So far, most of the vaccines that we've all gotten as kids that are out in use now use one of just a few technologies. And so let me describe those, and then I'll shift and talk about the ways that COVID-19 is being approached. Right, so as far as examples go, the Salk injectable polio vaccine was created by growing live polio virus in the laboratory and then chemically treating it so it's inactivated, unable to infect and replicate. So I've indicated that on the image here just with an X. Otherwise, this looks like the virus that we've been discussing along, but now it's inactivated and can infect. The Sabin oral polio vaccine, in contrast, is created by using a live virus that's genetically weakened, and it's lost its ability to cause disease. So here you see a white V indicating it's less effective in it. And then just as another example, the human papilloma virus for genital warts, that vaccine uses a subunit of the virus, essentially just a piece of the spike protein, for example. What all of these approaches and vaccines have in common is the vaccines deliver the protein needed to stimulate the immune response, like this red spike protein, but in a way that won't really cause disease. And then you can get a primary response, and so you're ready for, if you get an infection, with a secondary response. Now, for COVID-19, there are over 100 universities and companies working on a vaccine with lots of different approaches, both traditional and novel. So for example, Sinovac is a Chinese company using an inactivated vaccine.
Gary, I think you need to screen share there. I'm not sure we're seeing what's on your screen.
Are you not?
No.
Let me see what I can get back. Well, there had to be a technical issue. Do you see it now?
Yes, we're seeing it now. Thanks, Cary.
Okay. Thank you. Yeah, let me just run through these quickly then to show the examples. The inactivated polio vaccine, the live attenuated vaccine, the subunit. So all of these are using various ways to easily or safely deliver those proteins. The Sinovac vaccine for COVID-19 is using the Salk polio vaccine approach. And then where I left off, some novel approaches, the University of Oxford is actually using a chimpanzee adenovirus. Now, adenovirus is of a type of virus that causes a common cold. It's a chimpanzee virus, so it doesn't cause disease in humans. But what they've done is genetically engineered this virus to carry this COVID-19 or the red spike protein like I've got it drawn here. So it can, again, safely deliver it. It infects cells, but it doesn't go any further than that. It doesn't replicate and spread, but it can still stimulate the immune response, hopefully. And then finally, one other novel example, Moderna is using an RNA, injecting that as a vaccine. So it finds its way into cells like this lung cell, for example. And then since RNA is a genetic information, it programs that cell to make the spike protein. So hopefully I'm back with you now. The question then is to sort of come to the end, what is it going to take? We're all interested in this, to bring a vaccine to market. So normally a vaccine has to go through several steps of testing in lab and in animal tests before it's shown to likely to be able to work in humans. And then it goes through 3 phases of human clinical trials. The first phase is with a small number of people, maybe a dozen or so, and is given to them to see that not whether it produces an immune response, but just to see if that it doesn't cause any harm. And if that's successful, a phase 2 trial might involve several dozen or a few hundred people where it's given to them, and then laboratory tests are done to see if they develop antibodies, say, that might be protective. And then finally, in a phase 3 trial, it could involve tens of thousands of people and actually take several years. The vaccine is given to large groups of people. Some of them, they get the vaccine, some of them controls, and then they're followed over time to see what the rates of infection are. And Erin, I apologize if I didn't use the right term there for that study. So what about COVID-19? Of course, we don't want this to drag out for years and years. We're hopeful we can get a vaccine in the 12 to 18 months that has been suggested. And I think there's reason to be optimistic about that. The companies and universities that have already done some limited clinical trials have shown some promise with those results. And I think that I know that the government has, under emergency circumstances like this, ways to sort of shortcut the approval process. So for example, rather than having a full drawn out phase 3 clinical trial, if a vaccine is available and there's an outbreak in a major city, the vaccine might be given to individuals as a sort of a truncated phase 3 trial and hope that it can prevent widespread infection and disease. Ultimately, even though that is a long timetable, this is still going to take time. And I think the most optimistic estimates are looking at late this year, and that may be too optimistic, but there might be a vaccine for the kind of trial outbreak I talked about. And then eventually we're probably looking into late next year before there's something more widely available. And this is just if all things go perfectly well. Fortunately, there are 100 different companies or more and laboratories working on vaccines. So if one approach doesn't work, if many don't work, which is likely they won't, hopefully there'll be a few that will. So Cary, I'll stop there and turn it back over to you.
Thanks so much, Cary. We are going to have a few questions for you in a couple of minutes, but we'll turn it over to John now. Dr. McCullers, you're on the front lines there in Memphis. We're all concerned about transmission, about contracting this virus. What can you tell us about transmission?
Absolutely. Well, thanks for inviting me to be part of this, Cary. And I'll just apologize if I have trouble with my internet connection. I'm outside of Memphis right now for a couple of days. So I've been in a really interesting position during this pandemic in that In my early career, I was a virologist and immunologist. I studied influenza viruses. I studied pandemic and pandemic preparedness. Did a lot of work with WHO, with CDC, with the United States Congress on pandemic preparedness. And then over the last 8 years, I've been more in an administrative role, now working with hospitals and health systems as the pediatrician in chief at Le Bonheur, and more recently as the Dean of Clinical Affairs at the College of Medicine at UTHSC. And so as the pandemic came into Memphis and into the United States, I was in a position where I had both the scientific side of things as well as the healthcare hospital patient-focused side of things. And part of what I've been doing is helping the city and the county by serving on the Joint City-County Task Force to help how do we deal with COVID, but then also being on this small subgroup that's looked at how do we reopen Memphis and instituting the back to business plan and the phase 1 and the phase 2 that we've been hearing about. And so what I thought I'd talk a little bit about today is a little bit of the science behind what do we know about transmission? How do you get this virus? How does it pass between people? What do we don't know? There's a lot we don't know about this. But how are we using what we do know or what we think we know to guide the public policy around reopening and some of the phases and the staging that we're doing? So what I want to start with a little bit is just, kind of the time course of infection and when is a person infectious. So if you're exposed to the virus, you contract the virus, you have a couple of days where you are asymptomatic and you're not shedding virus yet. This is a period where the virus hasn't grown up in your body to the extent that it is shed into the environment in any great amount. If you develop symptoms, you'll typically develop symptoms somewhere in the 2 to 5 days after you're infected. And your viral expression, the amount of virus that you're putting out, typically peaks about the day before you develop symptoms. If you never develop symptoms and it develops about the same time course, and we think develops a little bit lower level of virus. Most people are infectious then for around 7 to 10 days, up in extreme cases maybe to 3 weeks, but we think on average it's about 10 days you're infectious. So after about 2 weeks, most people are no longer infectious because they've developed those neutralizing antibodies that Gary talked about, and even if you have virus in your body, it's not being expressed in a manner that can infect other people. So we have that 10-day to 14-day roughly period where you're putting out virus. Well, let's talk a little bit about the numbers. We talk about, how many viruses do you need to get inside your body to infect you? And some of the numbers that have been put out there are maybe you need about 1,000 viral particles to get into you, either by breathing them in, by rubbing them into a mucous membrane from your hands, or by some other, by ingesting them or some other mechanism. That number is really going to vary extensively with your immune system and your age and your other comorbidities. But let's just use 1,000 viral particles as a guide. A person who is infectious at the peak of their infectious, if they were to cough or to sneeze, can put out a massive number of viral particles. We're talking 200,000 to 200 million viral particles in a single large cough. So the infectious dose, they're putting out a massive amount of this virus that could affect a lot of people if people were to breathe it in and get it into themselves. This is one of the reasons there's such an infectious virus. You need kind of a lowish number of virus particles to infect, and people put out a lot of it during the peak when they're either just pre-symptomatic or when they're starting to have symptoms. So, but how much gets into the environment differs a little bit by what you're doing and by some of the characteristics of the host, as well as the environment. So a baby has a shorter respiratory tract, so the virus has a quicker path to get out, but doesn't produce as forceful a cough as does a full-grown adult. An adult has a straighter respiratory tract, so there's a straighter line for the virus to get out instead of some of the floppy tissue that's within a baby. So there's a lot of host characteristics to determine how much virus gets out and what form it gets out in. We know that almost all respiratory viruses exist in a number of forms as they come out of the body. Some virus, in almost every case, is aerosolized, meaning it's up in the air in very tiny particles that can float around for a long time within the air. We know that many of these viruses are in very small particles, that you may just be breathing out these small particles just with normally sitting there with quiet breathing. They may float around you in a haze and then slowly settle to the ground. And of course, if you're coughing or sneezing, we talk a lot about the large particles that get into the air but then settle very rapidly due to gravity. And how much of the virus is in each of those modes in each person depends a little bit on the virus, depends a lot on your host characteristics. I just dropped off a second there.
Okay, we seem to have lost John for a moment there. John, are you with us?
I'm back, I hope. Can you hear me now?
I can,
Okay,
thank
so
you.
I dropped off real quickly. So as I said, it depends a lot on kind of a lot of different characteristics. It's a very complex thing. And so when you hear the media trying to talk about this, they often have difficulty expressing what it means to transmit or simplifying it down. And often they oversimplify what it means to transmit. But we know these viruses can get out into the air in a number of different ways. Coughing, we know, can release a large number of particles. A cough, the particles can be traveling at 50 miles an hour and can go typically 5 to 10 feet. We talk about that 6-foot rule because that's where most of the particles will settle. These large particles will settle out of the air. A sneeze can travel at 200 miles an hour and can go 30 or 40 feet across the room. So a sneeze in an adult really can spread a large amount of virus across a very large volume. We know that just normal speech, so sitting around talking quietly, we do have a number of viral particles that come out. It may be several orders of magnitude less than with a cough or a sneeze, but just quiet talking, quiet breathing can put that out. Louder talking means more viral particles, which means a farther distance of viral particles. And we know that singing is a particular risk factor. Not only are you getting virus from very low in the respiratory tract, where it's more likely to be aerosolized and float in the air and go much farther, but it's being expelled more forcefully and more virus is getting out. So as we've looked at some of these things we call super spreader events, where you talk about these big outbreaks in South Korea and Chicago, original outbreak in Boston. There's been a number of these with religious ceremonies across the country. They all have a few things in common that we're seeing. The first is they're typically indoors with poor ventilation. So there's less room for all these viral particles that are getting released to go anywhere. If they're outdoors, I may be releasing 200 million viral particles, but they quickly disperse out into the air. If we're in a closed situation where there's poor ventilation, crowding, those viral particles stay around. Many of them have involved singing or speaking, so there's a number of choir associated infections that have happened. There's a number of public speaking, concert events, things like that, where there's loud talking, speaking, shouting, or singing have been involved. And then crowding. We know that the more points of social contact between people, the more opportunities for the virus to spread, and particularly indoor crowding, where there is an opportunity for that virus to spread. This is when we see most of our transmission. So, and one other note is just to say, we do talk a lot about what we call faux mic transmission, and that's the idea that you can cough or sneeze or breathe on a surface. The virus will be present on the surface. You may pick it up on your hands and then rub it onto your mucous membranes, your mouth or your nose. We think most of the outbreaks that we've seen are due to these large particles that are being coughed out or being sneezed out, as opposed to the faux mic transmission. But faux mic transmission may be more important in certain closed situations like prisons or nursing homes or within a family unit. But I think most of the focus has been on this large particle spread, because that's what's causing these big events that we've seen, these super spreader events. All right, so what does this knowledge about transmission mean about prevention? So how do you prevent it? Well, the first and the most obvious way is just avoidance, right? Don't go around a lot of people. If you're going around people, don't do it in a close indoor space where there's crowding, where the virus can't disperse easily. Don't have physical contact with others, and don't be around people who are sick. So those are kind of the easy part. We use the 6-foot social distancing rule a lot, again, because that's where most viral particles settle out from coughing. And in typical breathing, most of the viral particles from typical just quiet breathing or quiet speech don't go beyond 6 feet. Sneezing, heavy coughing, singing, the virus can go a lot farther than that, so the 6 feet doesn't particularly protect you. Mask use is a very important one, a face covering or a mask. And this does two things for us. The first is, And this is what we hear mostly in the media is if you have the virus and you're coughing or sneezing, it's going to trap all those viral particles so they aren't shooting across the room, aren't spreading out through the room. And that probably in the public health setting is the most important use for masks at this time, is prevention of all that virus getting out. But what's lost a little bit is the fact that the mask also protects you. Because obviously if you're inhaling or if you're in a room where somebody is coughing or sneezing, if those particles can't get in to you and can't get past this barrier, you're less likely to get infected. The dose you're going to get is going to be less because the mask is going to filter some of that out. So one of the really important concepts to take away from this talk is the risk of infection. There's an equation. The risk of infection is equal to the dose you're experiencing times the time you're exposed to it. So you can be exposed to a very small dose just sitting next to somebody in a classroom or sitting next to them at the dinner table. And if that very small dose, if you're there for 2 hours or you're sitting in a conference with them for 2 hours, that small dose over that 2 hours, you may be something that gives you an infection. As opposed to a very large dose, somebody coughs directly on you, you may only need a minute or two to be in the presence of that person to get that. So again, if we can think about our behaviors and tailor them to the situation, and that if I'm going to the grocery store, I'm only going to be around any other person in there for a few seconds to a few minutes. If I'm wearing a mask to protect myself, I'm trying to keep my distance, I'm at very, very little risk for catching COVID, even if that person is very ill and putting out a lot of virus, because although the dose is higher, my time of exposure is lower. If I'm sitting in a restaurant for an hour and a half and the person at the table next to me, even if they're 6 feet away, is putting all these viral particles into the air and I'm being exposed to the lower dose for an hour and a half, I'm more likely to get the virus. Again, so you can control what you're doing by staying out of the crowded indoor spaces, staying away from 6 people, making those interactions brief, making choices about how long I spend next to somebody, whether I use face covering as protection, and what am I getting myself into in terms of being around people who may potentially be infected. And then the last one, again, for the faux mic spread, where you may pick it up off a surface, bring it up to your face. This is what we talk about, the hand hygiene, the alcohol use, washing your hands. Anytime you may come into contact with any surface that may harbor the virus, go ahead and wash your hands, and that's the protection that you need. Okay, so let's talk a little bit about the reopening and how we've used some of this data to decide how we're going to reopen. And so again, the first thing we think about is we talked a lot about the crowded rooms, the indoors, and a lot of people close together. So how we've tried to approach this, and nationally it's being approached, is looking at indoor spaces where people get together and thinking about capacity. We want to reduce crowds, so we're going to say social distance, stay 6 feet away, wear a mask. That's all going to protect us. But then we're going to also say, let's reduce the number of people that can be in any indoor venue to 25% or 50% or 75%. So that's been kind of one of the first things we said, that as we entered phase one, let's have certain businesses be at 25%, let's have restaurants be at 50%, and let's keep that 6 foot as well, and encourage outdoors over indoors. So that means that a lot of businesses that we think could do that very easily. So retail, a big box retailer, you don't have to come within 6 feet of anybody. Those kind of went into phase one because it's easy to set capacity limits, easy to stay 6 feet away. Phase two now, we're bringing in some of the more contact-oriented things. So again, you have to be within 6 feet. You're losing that social distancing. So this is some of the contact sports we're talking about. This is hair salons, nail salons, massage, tattoo, those sort of things where you have to be in personal physical contact. You're breaking the 6 foot rule, a little more riskier. We're increasing capacity in phase two, also going from 25 to 50% in many of the retail. Again, loosening up some of those capacity restrictions, but still telling people if you have to go indoors, try to make it brief so that your time of exposure is low. And then we've upped this number of this group gathering number from 10 to 50. Again, that idea that the more people are together, the more contact points there are, the more likely one person is to spread it to others. And we just have to be able to open up some of those things. And then as we move into phase 3, it'll reduce the capacity a little bit more. It'll open up not just contact sports, but a lot of kind of the intensive things like scholastic contact training and practices and things like that. So as we talked about this in the city-county task force, we've really had to spend a lot of time with a lot of sort of special use cases where you say, well, how do you apply our knowledge of transmission, our knowledge of epidemiology to these special things? And so one of the ones we've really struggled with is weddings. So if you think about it, weddings, you want to have a lot of people indoors. They want to be close together. You're going to serve food, so it's kind of like a restaurant. How do you space? They're going to have a bar. It's like a bar. People are drinking. Are going to have your social distancing breakdown. They're going to want to have a band with people singing and a lot of virus coming out from the singers. How do you safely put on a wedding or some event like that with all these different variables? So it's a lot of work to kind of think through all those different things, and how do you set up some rules of engagement for an event planner to be doing this. We had to look at the opening of Graceland. So that was when we talked about how many people can be in the jungle room. How big is that room? What's the capacity? We looked at the opening of the zoo. The zoo had great protocols for how do they keep people apart. It's an outdoor venue. They closed the indoor spaces. They had good hand hygiene. They looked at their restaurant facilities and put in rules for those. Just a fantastic job. So we're kind of going through all these different events and applying what we know about transmission, what we know about how people can protect themselves, and then using that to craft these admittedly imperfect phased reopening policies and specialty reopening policies for a number of these one-off events. So I'll stop there and be happy to take questions with the group as we go along.
Okay, well, thank you very much, John. That was really fascinating, and it reminds me that this session is being recorded, so if we want to listen, and we'll have that opportunity. We've gotten quite a few questions along the way. I did say to the panelists before we started that when we came to this point in the webinar, we would open it up to the three of them in case they wanted to ask questions to each other or make comments. I'll take a look at their face.
I have a question for John. So what are the triggers that would cause us to regress from one phase to an earlier phase here in Memphis?
Yeah, so they're really the same triggers we're using to advance, and those are, we want to see the case counts, the rate of new cases being stable or declining. We want to see capacity, which is very important. Our ICU capacity in the hospitals stay stable at where we think we want to have testing available at a capacity where we can monitor the number of cases we see. And we want to have our health department's response, our contact tracing, be able to handle that. So, you know, we expect we're going to see some rising cases this first few weeks. We've seen that little bit of bump the last week. A lot of that is due to some nursing homes where we know there's been some cases and a lot of intensive testing in nursing homes. But in general, we're not surprised to see the case numbers go up a little bit. That doesn't worry us so much. But if we start to lose our hospital capacity, or if the new cases started to overwhelm the health department, then we would think about going back a phase and getting it back under control. That's kind of how we think about it right now. We want to open it up more, and as long as the capacity is there to manage it, and this is really managing the infection, managing risk, then we feel comfortable kind of where we're going. I'll return a question to you, Erin, if that's okay.
Sure.
And we look at the media and we see a lot of talk about these models, and most of the focus seems to be on what can the models predict is going to happen in the future. And I think what I heard you say is that the models are good for these what if situations. And I've always thought about the models being, you know, if I do A, what happens? If I do B, what happens? Relative to each other, but not I'm going to predict exactly what happens 6 months. You want to talk about that?
Yeah. So in mathematical modeling in general, once you've built your model, one of the common practices is to do what's called uncertainty analysis. So we can't know for sure what, we can't pinpoint an exact value of, okay, well, this is exactly the value in all cases for what the transmission rate is. right? So even as you were saying, right, transmission rate can be very case dependent, very individual dependent. And so when you run the model, you would run it over a variety of different reasonable parameter sets so that you can test the scale and the scope of what the output of predictions would be. And similarly, in terms of making predictions, you wouldn't say, okay, well, this is the exact thing that is going to happen. But most of the predictions that are made, you'll see well, I don't know that this is what always gets reported, right? But there is a range of what is expected to happen. And it's what is expected to happen given the various assumptions that have gone into the model. So John, as you said, right, the model, it makes predictions for certain scenarios. And if the conditions that have gone into the model are what actually take place, then the model should be a fairly good predictor as to what we would expect to actually see happen in the real world. But if the model isn't accounting for something, then what comes out of the model is not going to be that great, because what went into the model, wasn't the complete picture of what we needed. Does that answer your question, John?
Yeah, that's great. I don't think that's understood real well by the media sometimes. They want to focus on that number and how it changes day to day after the case change or where we open something up. Maybe I could bring Gary in for a second too. And one of the things that, again, going back to what the media report and this talk about 6 months or 12 months or 18 months for a vaccine. And what you talked about, Gary, was some of that process to get us there, to get that vaccine ready in the phases and so on. But what I don't hear talked about is the issues around manufacturing and distribution. And can we even make 350 million doses for the US, much less for the rest of the world? And would it take years to even do that?
From what I've read, and this is not not an area that I follow in my research or anything, but I think a lot of governments and companies are putting the resources forward now in anticipation of when they'll have a vaccine available. There's going to be some overlap in if a company is getting something promising, they'll start cranking up doses as much as they can in the hopes that it's going to prove to be effective. That way, as soon as there's some approval, they can get it into the market. But it's not just making the vaccine, right? It's making sure there are enough vials and syringes and alcohol pads and everything else necessary, plus the tremendous amount of logistics to get it out and to get it administered. So yeah, I think it's very optimistic to get that. I have seen some of those reports and discussion of that, but I agree with you. It's as much of a problem, I think, as the science behind it. John, let me ask you one then. And your background, I understand, is in influenza. And so I think maybe a question that's waiting in the queue I could anticipate is, are we likely to have a vaccine for something like COVID-19 that we take once or twice? Or is it something that's going to have to be yearly like we do for influenza? And so maybe would you mind talking just a little bit about some differences in influenza that would affect that?
Yeah, absolutely. So, there's a couple of differences with influenza compared to the, novel coronavirus, the SARS-CoV-2. And the first is we have multiple different strains of influenza circulating at the same time that do cause severe disease. We have 4 human coronaviruses that have been circulating for the last couple of centuries in humans, but they cause very, very mild disease. They cause just a common cold. The SARS coronaviruses that have broken out, SARS-1, MERS, and now SARS-2, cause very severe disease. And obviously there's only one of those still circulating. So that's the first thing, is that flu, you can have a wave of one and then have a wave of another in the same year. Whereas with this one, we expect it's just going to be the one. Hopefully we don't get more of these coming out and establishing a foothold. And the second is flu, because of the way it's constructed as a virus that can reassort and that has an intense, what we call antigenic drift, with changing every year. We have to reformulate the vaccine every year for it, or every couple of years for each of those different strains that are circulating. The coronavirus, although it is an RNA virus and it does undergo mutation like flu does, doesn't seem to change its surface antigen as rapidly as influenza viruses. So we're hopeful that we're going to have longer-term immunity. We know you have longer-term immunity to human coronaviruses that have been circulating for a long time. We're hopeful of that. We don't know that. We do know that these viruses changed quite a bit in their spike proteins as they came out of animals. And so there's the chance that as it adapts to humans, it'll change and we may have to reformulate the vaccine, but hopefully not every year like we did with flu. At least that's my take on it right now.
Yeah, I do find it interesting that the coronavirus seems to have proofreading ability, so that as it replicates errors that crop up, it repairs those, makes it more like the original, which influenza does not have. So that makes flu more susceptible to rapid change.
Yeah, and flu uses that as a survival mechanism. It exists in what we call a quasi-species, where it mutates, and there's just millions of different varieties of it in this cloud of viruses that you're breathing out. And so if one works in a human host, it's going to survive, as opposed to many other viruses, which all look the same. So it's a little different strategy.
Mm-hmm.
Let me jump in here. We've gotten so many questions. You'll be interested in that. Let me throw one out that I guess to all of you. Regarding testing, what are your thoughts on testing? Specifically, testing for the virus as compared to testing for antibodies, and how we might use the results of both of those.
Well, so
Yeah,
speaking from a modeling perspective, more data would be better. So if we want to be able to construct mathematical models that are able to make more accurate predictions, we need more data to build those models upon. So if we have a better understanding of the number of people that are infected in a given moment, but also if we have a better understanding of the number of people who, through antibody testing, we can determine perhaps have some immunity, we can use that information in how we construct a model. Say if we wanted to look at some vaccination strategies going forward, it would be useful to know in constructing a vaccination campaign and making predictions what proportion of a population already has some level of immunity when going into designing a vaccination campaign and testing different vaccination campaigns through modeling, right? So you can construct the models where you can look at different vaccination campaigns and how they would play out in the models before you actually deploy them on the ground.
That's a great point, Erin. And I've been involved with a lot of the work we've been doing around testing, both locally in the county as well as thinking about the use of testing. I've been consulting with a lot of businesses around how do businesses that go back to work use testing for the virus and potentially later on antibody testing. And one of the important things that I try to get across right now is that these are really imperfect tests, and you have to understand the ways in which they're imperfect if you want to use them. And I talk about the false negative rate. So even the best test for infection we have right now, the PCR, only gets about 4 out of 5 right. It'll miss 1 out of 5 positive cases. And then the false positive rate, which is not bad right now for the PCR test if you're testing somebody with symptoms, but if you're testing a lot of people who are asymptomatic and are less likely to have the virus, it really makes it a lot more likely that you'll have false positives. And having businesses understand what that means, for their testing regimens is really important. The antibody test is also, right now the ones that are out there are terrible tests, so don't waste your time getting tested right now with the current antibody test. They're just so inaccurate. They're not terribly useful, but this is going to be something that, Rhodes announced they're going back to school this fall with some, on campus in some manner. And this is something that maybe in the middle of the fall or maybe in the spring, we will have antibody testing will be improved to the point where it has utility to test, say, all the students or a certain set of students, or maybe it's just the teachers, test the teachers and see who's immune and who can go into classroom setting, right, without having to worry too much. But we're not there yet. But I think in 3 or 4 months, we'll be able to use antibody testing for those sort of questions that you might want to ask.
And what do we know now about the level or the length of any kind of immunity that might be experienced from exposure?
We know very little, I would say. I think based on experience with similar types of viruses, prospects are fairly good that that antibodies will persist over time. It doesn't take a large amount of antibody presence. I talked about the secondary response with a more rapid response. You see reports where, well, yes, people get neutralizing antibodies if they're infected, but over time the amount of virus drops off. Well, that's common for any kind of viral infection or any kind of immunization. But this persistence of those memory cells and the ability to rapidly respond on a subsequent infection, it's important. And it's not necessarily the case that people will not become infected a second time around. Even a good scenario is if someone becomes infected and they have very mild or inapparent symptoms, or if they become infected, but their ability to transmit is limited in that. John, you probably would want to have more to say about that as well.
And I'll just echo what Gary said, and that there is a lot we don't know about this. You know, we do think you're going to have immunity if you develop a certain level of antibody response, and we'll be able to measure that antibody response both in terms of the magnitude of the response and how well it neutralizes. We can already do the neutralization assay at UT, where our ELISA now is in a validation stage where we'll be able to titer your antibodies. So we're hopeful that you're going to, everything we know about virology and immunology says you're going to be protected for some period of time. Whether that's 2 years or 20 years is an open question, but we're hopeful at least it's a couple of years, right, as we get through this. I will say that this question that gets asked a lot about can you be reinfected shortly afterwards, in the months afterwards, the newest data we have is that there's been a number of studies now in monkeys that show that if you give the monkeys the virus, they produce antibody, you cannot reinfect these monkeys. So, and we think that's the same thing going to happen with humans, although we haven't obviously tested it in that manner in humans yet.
Just following up on that, there are obviously reports that people are testing positive, then testing negative, and then testing positive again. But I think that reflects the inaccuracy of the test that you talked about earlier.
I think it's two things. One is the test is very inaccurate, and you may have thought they were infected, they weren't, and then they catch it, right? And some of this is being done in prisons and other places. But there's also a phenomena we know very well with RNA-based viruses that you can have viral persistence for months in your body, but it's not infectious. And we can show in children with RSV, another RNA virus, that they will have the virus or pieces of the virus in their body for months, but once they raise neutralizing antibody, you can no longer detect infectious virus. You can't culture the virus anymore. So what we think is happening is that people are infected, their immune system knocks the virus down to a very low level. It's at the limit of detection for PCR. And so they may test negative one day, they may test positive the next day. You know, you worry that they got over it and got a new infection, but it's really just that virus is persisting in the body, but they're not infectious is the good news. And the South Korea CDC has studied this now and shown that these ones that are positive, negative, positive again, you can't culture the virus from them, so they're not infectious, which is good news.
There's a trade-off very often in transmission and how lethal a virus is. If it's extremely lethal and very quick, it's not so good at transmitting it, not so efficient. And over time, I know that some viruses have evolved in ways that essentially are becoming less lethal. Maybe perhaps one of the coronaviruses that are associated with common cold might be an example of that over a long period of time. Do you see any evidence of that? Would you guess that that might be the way that this virus could go, given enough time?
Yeah, so this was a major focus of my research on influenza. As pandemic viruses come in, they're very virulent. Over time, they adapt, they lose that virulence because, obviously if you make somebody really sick, they're less likely to infect other people because nobody goes around somebody that's really sick. So the end stage for a virus is something like a herpes virus that infects a lot of people, causes very limited symptoms, so people don't know they're passing it around. It can transmit very easily. The coronaviruses, we believe they probably came in and were more virulent when they came in, the 4 human coronaviruses. Now all they cause is the common cold. And what we would hope is that the same thing will happen over time with COVID-19. If we're unable to eliminate it, and I doubt we will, then over time we'd love for it to adapt and become, less deadly at, as it adapts to humans. We'll see. It's a great question that we have to follow.
John, as a pediatrician, it seems that this virus is less virulent or less symptomatic in children. And so would you think that over time, as the population is more widely infected, in a couple of dozen years from now, children tend to get infected with this as they do with the 2 other coronaviruses that cause mild symptoms? And then so they aren't exposed as adults when they might be more susceptible to more severe disease. I also, related to that, read a report that there's a hypothesis that one of those 2 circulating more cold-like coronaviruses that are in humans may have caused a pandemic back in the 1800s that was thought to be flu at the time, but now maybe thought to be that coronavirus.
Yeah, and we've gone back through the history books and looked at these, so-called pandemics of influenza-like illness and assigned them to flu, but they may very well have been a lot of coronaviruses in the past. It's a great question, and we don't know too much beyond the 1889 influenza pandemic. We know that was influenza, and everything before that could have been corona or flu. Just as easily. So that's a great question. The kids versus adults thing, we don't have any idea what that is and why your immune system reacts differently. We know that a lot of the disease and damage is due to coagulation deficits, it's due to inflammation. There must be something different about the older, either the coagulation or inflammation systems in elderly adults, or maybe their immune experience. We know that particularly elderly adults who have been exposed to CMV in the past begin to have problems with their T-cell repertoire, and their T-cells don't react the way they are supposed to. They become more clonal and they can't react to some viruses as well. Maybe that's a factor, but it's a lot of speculation right now. We just don't know why this doesn't affect kids as much as it does adults, besides the obvious stuff of adults are more likely to have cardiac disease and pulmonary disease, which makes your risk of death higher.
So I have another question. So there has been a lot of reporting about there are severe cases and mild cases, though the mild cases still sound pretty horrendous. So what do we know about the virus, or maybe the viral load in the patients that are having these more severe cases versus the ones that are having the mild cases?
Yeah, so there's one implicit question in that, and that's if you get a higher dose, do you have more severe disease? The evidence we have for that is that often healthcare workers, compared to their same age peers, seem to have worse disease, and we think healthcare workers, when they're infected, get a larger dose because they're in, close to infected patients with aerosolized, large amounts of virus. It's not definitive, but at least that's the evidence that we have. So that's one of the questions. The mild versus severe, I think, is a difficult one to sort out, because how do you define it? And we typically define that by, are you in the hospital or not, right? And different people will get in the hospital for different reasons. For years, we've thought that asthmatics had worse disease from flu because they get in the hospital at a really high rate. But it turns out asthmatics are actually protected from severe disease from the flu. They get in the hospital more because they have asthma, and the asthma puts them in the hospital when they catch the flu. So it's a really difficult question to say, really, what is severe COVID-19? because one hospital may admit a lot of patients, another hospital may admit very few, and the criteria for that, other than you need to be in intensive care. I know if you need to be in intensive care, then you're ill. But you know, the other ways we define it are so nebulous. And for somebody like you, or for an epidemiologist who wants to work on, you know, outcomes versus this, you know, dichotomous, are they more ill or less ill? It's very hard to do.
I would add that the severity of disease has a lot to do not just with the virus, but also with the immune response to the virus. And so, and it's not clear at all what the various characteristics are that lead to some of those more severe outcomes. So that's just another unknown there, I suppose, in the equation.
This changes subjects a little bit. There's a really practical question. There's some confusion about cloth masks. It seems that they may protect other people from your sneezing or coughing. Do they also protect you?
Yeah, so they do protect you as well. Obviously, how well the mask fits is important because you don't want the virus going around the sides. How many layers you have and what's the density of the weave can help with some of those larger particles getting trapped. And again, the major effect in a population basis is probably keeping you from coughing a bunch of particles out and infecting a lot of other people. But for the mask wearer, you're probably more concerned. This does have some modest protection for a short period of time. That's how I express it. I say, and in the healthcare setting, we know that if you're wearing a mask in a patient's room, you're protected for about 10 minutes from reasonable contact. Now, obviously, the higher the quality of the mask, an N95 respirator is a much higher quality in terms of the amount of viral particles it can filter. But a cloth mask does provide some protection, yes.
Okay. John, I lost a little bit of your audio at the end there. I have to apologize that we're getting close.
I believe we're losing Cary's audio rather than the other way around.
I don't have time to ask all of them now. There are probably 50 or more. Just to close it out, could I ask all of you one particular question, and that is, what has surprised you the most about this virus?
Yeah, I'll say for the virus, this kids versus older adults thing, I just don't understand. There's very few testable hypotheses that fit what we know about it so far. I think broader in terms of the pandemic, the thing that surprised me is that we have not seen more civil disobedience and civil unrest. I would have expected a lot worse, you know, for what we've had to do to get this first wave under control. And I think for the most part, we've been very well behaved. And I think particularly in Memphis, people have done what they needed to do and have been responsive to the public health message. And I think that's a great point for our city, but it has surprised me that we haven't seen more trouble.
Mm-hmm.
What surprises me most is the subject that I spoke on, the fact that there are over 100, some estimates 150, I don't have an exact number, of companies and laboratories working on a vaccine, racing to get it out. Most of the companies indicating that they're going to produce it at cost, not trying to make large profits on it, and try to knock this out in a phenomenal amount of time. So we'll see if that actually happens, but certainly the efforts are there.
I would say that the thing that has surprised me the most, so in working on epidemiological modeling, I have relied on the CDC for a lot of data over the years, and I have been surprised and disappointed at the back seat that they have seemed to play during this pandemic. I have been super impressed with our city and the response that Memphis has made, but I have been surprised and disappointed at the lack of the front seat that the CDC could have taken and has not.
I'll just echo that, Erin. That is, it disappointed me so much. The messaging that's come out has been glaringly inaccurate in some cases, and then it's been confusing in others. And I can only think this is an interference from the federal side, because I know the people there very, very well, and they don't believe some of the stuff that they're saying. I know that.
It's disconcerting, John. Do any of you have any closing comments you want to make in a minute or two, and then I'll try to wrap up.
I would just like to say, so in studying epidemiology, I have had the opportunity to look at a lot of historical epidemics. And so I just want to say I'm excited about next week and looking at the role that history has to play and how we're thinking about coronavirus.
Thank you.
I'll just add a thanks again for everybody who's tuned in. I will be following, like Erin, the other sessions, and I'm excited that you've got 50 or more questions, and I wish we could be here to answer them all.
And
But
I'll just finish.
Sorry.
Yeah, I'll just finish by saying that again. I think Memphis has done a great job, and the people of Memphis have really done well. And we've been able to control this where a lot of other places our size haven't. But the next phase is going to be mask utilization. I'd love Erin to model the use of masks. We have to get up to a certain level in order to take that next step and start decreasing the rate of new cases per day. That's what's going to do it. If we can get everybody wearing a mask, I have no doubt that we can reduce transmission to negligible levels. So that's going to be a public health necessity.
Mm-hmm.
And finally, one very, very quick question to all of you. What resource out there that you would advise that the general public and educated public turn to learn more and to keep up?
I responded to one of the questions about that was posted. I forget exactly what the question was, but it was about the different case numbers and case per millions. And I posted a link to the Wikipedia page that has been fairly routinely updated. And you can sort by the number of cases, the number of deaths, the number of recoveries. But then there's a second table where it has all of the information in cases per million or deaths per million, and you can sort by those values as well. And it has 227 countries. So it's only as good as the reporting from those countries of their case counts, but that's a good resource to look at if you're interested in comparing data from different countries.
Mm-hmm.
Yeah, I'll say that we have a website, uthsc.edu/coronavirus, where we put up links to a lot of resources. We've put up some of the symposia we've done, if you want to go back and watch some of those, as well as an Ask the Expert, where I answered about 100 questions over the first month or so, but they're all out of date now, unfortunately, because things keep changing. But there's a lot of information up there that's useful. And one of the really fascinating things about this pandemic has been a lot of the really great sources for information and for kind of some of the thought leaders are not necessarily the CDC or the virologists that have studied this, but are just scientists who got an interest in this and put up a blog or a web page. And I follow a lot of those that are clear thinkers, although they're not necessarily, in the field to start with. And there's some good stuff out there if you look for it.
There is a lot of good stuff, and I don't have a specific thing to point to, but as in all advice we give our students and everything is to search carefully and consume wisely.
That's absolutely true. And I guess a lot of people are following the the Johns Hopkins Coronavirus Resource Center that has a lot of links up there. There are also a number of journals that have done some great work. New Scientist is one that I subscribe to and follow. It's very accessible to lay people. Well, I think we're going to have to draw this to a close. I'm really sorry to do that because, as I said, we had a lot of participation from the audience, a lot of questions. I want to thank our panelists. I'm very, very grateful that you were able to join us and contribute to this effort. Please join us next week. Same time, same place. Next week, we're going to have another great panel going to focus on pandemics in history and literature. You'll benefit at that point from having an even better moderator. So I'm sure you will enjoy that. Until then, we want you to be smart, be safe, take care of yourself, take care of your family, take care of your community. We will get through this together. From Rhodes College, good evening.